Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry and promotes the highest standards of patient care with today's top experts in the field. Now here's your host, Dr. Joel Berg.
Thank you for tuning in to Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. Thank you to our Pedo Teeth Talk sponsor, Hugh Freedy Group, for helping us bring you great content. We couldn't do this without them. Visit them at www.hughfreedy.com/APDcrowns. That's HUFREDY-group.com/APDcrowns. We are here today with Dr. Jennifer Cully. Dr. Cully is a board-certified pediatric dentist, full-time faculty member, and education scholar. She graduated from New Jersey Dental School in 2007 and completed her pediatric dentistry residency at Children's National Hospital in 2009. She also received her Master of Education in 2019 from the University of Cincinnati, where her thesis project was developing an oral health curriculum for third-year medical students and evaluating its impact. Dr. Cully has done extensive research in the areas of quality improvement, curriculum development, and education assessments. Recently, she has been working on the development and implementation of Entrustable Professional Activities, otherwise known as EPAs, for pediatric dental residents. Dr. Cully, thanks for being with us on Pedo Teeth Talk.
Thanks, Dr. Berg, for having me.
Well, this is really exciting. I think I've been waiting a long time. I first heard about your work and about this podcast that we were going to do, and we just finally getting together. So this is going to be really important for all of our members, for everybody involved in dental education, specifically pediatric dental resident education. So let's talk about trust before we define your work and Entrustable Professional Activities. How is this based on trust, and why is that important in healthcare?
Well, thank you for bringing up trust first. I think in everything that we do, from working with our colleagues, from taking care of patients, to sometimes even the healthcare systems that we work with, there is this element of trust that has to be there. And if we don't have trust, between patients and providers, then we can't adequately provide the care that we need to provide. And in a similar way, in an educational space, there has to be trust between a supervisor and a trainee, whether we're talking about in a dental school setting, when you're a dental student, or even as we get to the residency and fellowship stage.
So when we talk about trust, I can think of various meanings of trust. And when you talk about trust between the mentor, the attending doctor in a residency program, and the student/resident, trust is that they're out for my best interest. Is that a fair way of defining it in this instance?
Yeah, I think so. And that they're going to be able to provide the care that they say they can provide. And do that safely and effectively for the patients that we take care of. And, there are different types of trust when we look in the educational space. Sometimes we have to make decisions on the fly. We need something to be done right now. And we look at different things, qualities of the learner, quality of the supervisor, what that relationship is between them. And we make we call them ad hoc trust decisions versus kind of the area or the space that I like to research, and kind of where my interests lie are more in some of those summative trust decisions. So where are our long-term or our end goals looking at, when we looked at trust? And this is really what's done when we have multiple evaluations, and allows us to make a decision on what level of entrustment that learner needs to provide a certain activity or task or care.
So regarding this Entrustable Professional Activities, and I love the phrase, and EPAs, obviously, it's the other EPA, kind of rolls off your tongue. I think we're all going to be talking about this. Obviously, at the end of the day, is we don't want our graduates to be vulnerable to patients in society, that patient safety is really keyly, it's integrated into this EPA concept. So tell us a little more about patient safety and how this fits into why you chose, and tell us, how did you get into this EPA thing in the first place? Tell us about that, along with that.
Yeah, it was kind of interesting. I feel like some of my best thoughts happen when I am out for a run. So like outside of the workplace. And I was thinking about this in terms of sedations and in terms of like numbers of sedations versus quality of sedations and what that difference was. And so I found myself looking through tons of articles on Google, tons of articles on PubMed to see how assessments were being done. I thought about this from the perspective that I wanted to make sure that we were providing the safest care, and you need certain levels of knowledge, skills, attitudes to provide that care. And so what I found was that in medicine, they were using this idea of looking at safety from a trust perspective. And so kind of went down that pathway of reading articles, and one of the main kind of individuals that has done a lot of work in the EPA space is Ole Tenkate. And so in 2005, he was really the one that introduced this idea of putting trust in what I consider to be like the center of assessment. And so from a patient safety perspective, our goal, right, is to graduate residents that can take care of patients safely and effectively and without supervision.
Speaking of it without supervision, you just prompted me to think of something that's been in my mind for some time. And that is, first year residents are often less entrusted at the beginning, if that's the right word, than maybe second year or third year residents. And I remember reading the literature, maybe it was GME literature, about neurosurgery residents and how many cases of craniotomies do they have to do before they can do one unsupervised. Mm-hmm. So talk to us a little bit about how EPAs can be used to determine when somebody could, in the residency program, begin to perform a certain procedure unsupervised.
Sure. So I think it's important to understand that EPAs, when we talk about EPAs, we are not talking about the quality of the training. We are talking about like the task at hand. We're talking about the what we would expect a pediatric dentist or in the education space, a pediatric dental resident, what we would expect them to be able to perform. And I think that's a big distinction we need to make when we talk about dentistry, because when I was like going through and learning about this, they kept using the word competency in a lot of the medical literature, and I kept thinking back to class 2s in dental school. And that's not what medicine means by the idea of competency. They really look at it in this word of EPA. And so when you look at an EPA, there are several components to it. So obviously defining what the EPA is, defining what knowledge, skills, or attitudes are needed to accomplish that EPA. There's also information on what qualities of the trainee kind of build into that. And there are tons of different competency frameworks that you can find, in literature. And then after that, you have to really define when you would expect an individual learner to meet that EPA, and they don't all happen at the same time. So you might be in your training program and, similar to what you were saying, Dr. Berg, you might be able to do these things in year 1, but not do other things until year 2 or 3. And then as part of that EPA is really defining like what the actual expectation is. And as you progress through it, there's sometimes the idea that one EPA might end up nesting under another. So the example that we see a lot in medicine is for a, let's say, newer individual maybe taking blood pressure is an EPA at first, but then as they become more advanced in their training, that EPA for blood pressure gets nested under actually performing an entire H&P. And so that's how medicine has done it. When we've looked at dentistry, we've kind of thought about it in the same way, like, is this the same idea that, you might have an EPA on performing, let's say, or taking a medical history, right? And that might be something you achieve early on in your education, but then as you move along in your training, perhaps that gets nested under like managing a patient encounter, the entire, encounter.
Very interesting. So I could see how these could be confused with competencies, and I'm going to come to that in just a second. We will now pause for a word from our sponsor. Ufridi Group provides world-class products, services, and education, resulting in superior clinician outcomes. For more information, please visit www.ufridigroup.com/AAPD crowns. We are back with Dr. Jennifer Cully, who is teaching us about EPAs, or Entrustable Professional Activities. I'm getting really excited about learning more about this, and I'm still a little unclear. So perhaps on this confusion potential between competencies and EPAs, tell us a little more about that, and maybe give us an example of the distinction between the two that we would understand in pediatric dentistry.
Sure. So yeah, like I said, it is confusing because I think in dentistry, we're just so tuned to the actual procedure that we're doing. And like I mentioned, like thinking of having to do a class 2 amalgam competency. I don't even know if we do class 2 amalgam competencies anymore. But when we think of EPAs, we think of the descriptor of the work. So what are we actually doing in that moment versus the quality of the trainee is a competency, is what they look at in medicine. And so they might consider that, like if we were using the CAN meds is a type of framework that a lot of EPAs are based off of for qualities of learners. So that could be like medical expert or health advocate, or some of the qualities of the individual versus like the actual task. Like I said, in dentistry, that might be managing a patient encounter. So it's not really it's not really tied. The task is the work that we're doing, whereas the competency is the quality of the individuals or the qualities of the trainee.
So if I think of a pediatric dental example, and instead of saying amalgam, I'll say glass ionomer.
Yes.
So let's say I have a competency exam, which we often do in glass ionomer placement, a class 2 restoration using glass ionomer material. And for that competency, typically one might see like a competency form, and it's got all the elements in there, like did they assess the case right, and did they do proper behavior management, rubber dam placement, maybe, whatever it is. And they would check off, and it might be binary, completed or not, or it could be a score, whatever. That's how I understand a competency exam.
Sure.
So tell us what I just described as the competency, what would be the EPA part of that? Would it be just the description of the whole procedure overall, or what would it be?
So, in that EPA, you'd have to look at it, you'd have to define what your knowledge component might be. Then you'd have to look at like what your skills might be in terms of restorative dentistry for that specific procedure. And then the other component of it would be like the attitudes that follow. So like, are you altruistic? Like, were you doing the best for your patient in that moment? And so that's part of the challenge, right, with EPAs, is coming up with those specific measurable components of the EPA.
So an EPA could be the determination of the metrics. Would that be a fair way of saying it? What are the metrics for evaluation? Would that be an EPA in order to determine that the person is entrustable? Or is that not it?
Well, I think an EPA looks at, EPAs are helping to define the core kind of tasks of the profession. But the next part of that is then looking at like what the entrustment decision would actually be. So you have all of these parts of an EPA. So the knowledge, the skills, the attitudes that you need, how are you going to assess this? Like how many different, if you're going to use observations, like how many observations do you need? If you're going to look at different case presentations, how many of those do you need? And then once you kind of look at that all big picture, you come up with your entrustment decision. Some of these entrustment decisions are, kind of looking at what you could have done or retrospectively versus some of the more prospective scales, which is always looking at like what the individual can do, say, like in the future.
Okay. And in 2021, you mentioned there was a survey of program directors. It was published in Pediatric Dentistry. Tell us a little bit about the findings and how that connects to your work with EPAs.
Sure. So I think, one interesting thing with that study was one seeing, do dental people, excuse me, do pediatric dental residency program directors know about EPAs? It's a very common term in medicine. However, our study, thought maybe we just don't know about it. So it's hard to introduce something when people don't know what it is. And like I said, it's a confusing term. And so we found that in this study, 67% of program directors had not even heard of EPAs. And so we felt that was a good jumping off point that we needed to introduce this before we started saying, getting into the weeds of what it actually was. And then, it also, I think, fostered a discussion on, standardizing parameters. We have lots of different things out there, from CODA, from, the reference manual from the American Academy of Pediatric Dentistry, looking at, when residents take the qualifying exam for the American Board of Pediatric Dentistry, or the OCE. And so we were really trying to look and see if there was a way, when we started looking at developing EPAs, if we could put all of that together to really come up with what are the core tasks of a pediatric dentist.
And one of the findings was that 0 program directors felt that residency program graduation requirements should be time-based solely. In other words, you serve 2 years in the residency, I guess, versus some time requirements and also competency requirements. So tell us a little bit about that. And I mean, is there, do they feel that competency was enough, or you needed the time too? I guess the other direction.
Yeah. I think that specific information probably needs to be teased out a little bit more in future studies. Medicine has really been looking at this idea of doing time variable education. So there are some pediatric programs where you are identified like early on in medical school that you want to go into pediatrics. And so you flow very seamlessly from medical school right into pediatrics. And so looking at time, like solely looking at time-based training, because, I could imagine there would be a world where, maybe there were residents that would be able to graduate sooner, or maybe there are pediatric dental residents that might need to spend a little bit longer time. And so really looking at it from both perspectives, I think, is important. But I think that really needs to be teased out more in future studies.
This is really interesting. I'm gonna start reading about this after our talk today, and I can see this is going to be a thing. Speaking of being a thing, it's not a thing right now in dentistry. You said your research was in medicine, medical residents or medical students, but that was done at a hospital, right? At a children's hospital, your research in Cincinnati, is that correct?
Yeah, so most of the research on or the development of EPAs came out of my time there, and my research has been in looking specifically at dental EPAs. There aren't very many dental programs that use it. Orofacial pain is really the first one that had identified EPAs for their specialty. There are some dental schools now that are introducing EPAs into their curriculums, and I'm really looking forward to hearing, kind of how that goes, because I do think over time there will have to be a flow, between dental schools and pediatric dental residency programs, because there may be a moment where some of these EPAs that we've started to develop for pediatric dentistry could be accomplished in a dental school. And so that would be like that nesting idea, like it got done in dental school, so we don't necessarily have to spend a ton of time on it in pediatric dentistry residency programs.
Really interesting on that connection. It's kind of like how some dental schools require biochemistry before dental school, and some of them teach you biochemistry in the first year of dental school. I see that connection there. That could be very interesting, as we're trying to cram so much into the curriculum. If you're engaged in an EPA prior to the residency, it could save time for other things that you want to put into the curriculum. So that's very interesting opportunity. And it's cool to see that dental schools are starting to look at this, thanks to your work in part. So what's the current status of EPAs? You're talking about engaging a group of pediatric dentists, developing EPAs for pediatric dentistry. Tell us all about that, what you're doing.
Sure. So just, recently we worked with a group of pediatric dentists from kind of all different backgrounds and started to define what we thought were the core tasks of the profession. We developed or arranged them into 4 domains that we came up with: assessment and planning, provision of care, behavior guidance, and then professional development. And kind of underneath each of those 4 domains, we developed 16 EPAs. And right now, the next steps are really working on to fully develop those EPAs and gain consensus on them, and then hopefully implement them. So that's where we're at.
So can I find those somewhere in the literature? Can I identify that work, or is it published
Sure.
yet?
Yeah, the EPAs were published just recently in the Journal of Dental Education. And so you can see all 16 of those EPAs, and you can see how they were mapped to CODA standards, as well as like the blueprints from the American Board of Pediatric Dentistry for the qualifying exam and the oral clinical exam, which are accessible right on their website.
So if I look you up, I can find the article. Are you the lead author?
I am the lead author on it. Yes, you could find it. Yep.
This is fascinating stuff, and the kind of good information we want to get out to our pediatric dentistry community. In conclusion, Jennifer, tell us about the future. Where do you see this headed? I mean, are we going to eliminate some other metrics, or is this going to be superimposed on the existing metrics or characterizations of training? Tell us where we're headed with this, please.
I think, the first step is really making individuals knowledgeable of this. And I don't think it's strictly to pediatric dentistry education. I think this applies to all pediatric dentists, from, like I said, individuals that are educating residents to those that are hiring new dentists, as we move forward in the future. And so I think that's number one, is really coming up with a consensus on these in our field. And then after that, it's looking at the best way to pilot these at certain programs and then see what the implementation looks like. Because pediatric dentistry, we both know it moves so fast. Like, things change. And I think that's one of the nicest things about EPAs, is they are very much living documents, right? Like, we have an opportunity here to really define what the core tasks are and the core expectations are of a pediatric dentist. And so I'm really looking forward to engaging other individuals who are interested in this space, and hopefully continuing to, determine the best way to take care of our patients safely and effectively. And I think this is a good step in that direction.
Well, you've got me interested, so I'm going to be a follower. So I look forward to that. This was fantastic. I know we're going to be talking to you again. Really appreciate it. Thanks for being with us today on Pedo Teeth Talk.
Yeah, thanks for having me. I appreciate it.
Do you need additional CE hours but don't have time to travel to courses? Did you attend annual session and want to listen to the audio recordings? Check out AAPD's new Education Passport. The redesigned and improved Education Passport is AAPD's online learning center, where you can earn CE and listen to audio recordings from all of our continuing education courses and more. Visit educationpassport.aapd.org for more information. For 10% off any product, use discount code Teeth Talk in the Education Passport store. Pedo Teeth Talk is the show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry. Be sure to check out previous episodes of Pedo Teeth Talk, as well as our other podcast platform, Newly Erupted. All previous episodes are available on our website. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.